Hi, it's James Hamill from Course 3D and Chrome Guided Smile. And you're very welcome to what I hope is going to be a little series of short interviews with, let's describe them as influential people in implant dentistry. And it's quite a coup to have today as our first guest, Dr. Pynadath George. And myself and Pynadath have known each other for a number of years now. And over the past couple of years, 18 months, 12 months or thereabouts, we have been working on how guided surgery sits within the full arch market. Quite a controversial subject, and one that I know when we first brought it up wasn't very well received. Okay, not from you. So, but credit to Pynadath. Pynadath has opened his mind, and it's been super to work with him over the last 12 months or so. So let's do a quick introduction. So just introduce yourself, because unless people have been hiding under a rock, they will, I'm sure, have heard your name.
I don't know about that. Maybe if you do complex dentistry or complex full arch implant work. So my name is Pynadath George, but most people call me George. So I'm an implant dentist that's based in the northwest of England. Qualified from Liverpool for undergrad, the Eastman for restorative, Warwick for implantology, and Edinburgh for oral surgery. I did my specialist training in oral surgery there, 3 years full time. So yeah, that's me.
Yeah, and a huge part of what you do is education-based training.
Yeah. So I suppose our focus on education is purely complex work or advanced work. So I kind of, run a team that puts on education series for complex soft tissue work, complex apical endodontic surgery work, complex full arch, grafting, sinus grafting, as well as block grafting, zygomatic pterygoid implants. So yeah, a bit of and prosthetics, full arch prosthetics.
Yeah. And you know, a lot of people have been on your courses. I've spoken to a lot of people who've been there. Yeah. I've never been.
Have you? Yeah,
and I should go.
Yeah.
So
I'm sure your name was down for the Zygo course.
It was one.
Yeah.
And then I ran scared. The Zygos are scary.
I'm not going to do that.
So I suppose, you know, the point of having this conversation with you is to explore a little bit around your thoughts about guided surgery.
Yeah.
Okay. Because we know that it upsets a few people.
Yeah.
That'll be fair to say within the world that you operate in.
Yeah.
Okay. So, so let's, if we just go back a wee bit. So I introduced you, I suppose, to Chrome Guided Smile a while ago. And I suppose you've watched some of the development over that period of time.
Yes. Yeah.
And really when I contacted you, it was about how do we use these techniques for more complex cases.
Yeah.
Okay. Is it fair to say that now that you've gone through some of this process, that for, let's take conventional full arch work.
Yeah.
Do you think and do you feel like guided surgery has a nice sound role within that treatment modality?
For full arch?
Yeah, for standard conventional full arch.
So, you know, I get very specific. So do you mean full arch as in, because full arch also, you know, it's a broad-based term. So
yes.
Do you mean from FP1, 2, 3, RP4, 5?
Let's look at FP3 as a standard.
Yeah, so let's start with FP3. I don't think anyone can deny that full arch guided has a place in FP3. Yeah. That's without a doubt.
Yeah.
I actually, and you may be surprised to hear this, I actually think it has a stronger place in FP1 and FP2.
Yeah.
So I actually think that that's potentially the gold standard for FP1 and 2, because positioning is so critical. So if you get it wrong, then you're chasing your tail, and ask me how I know. So I think it's actually, you know, to do FP1 without, you know, really planned and you know, with a guide is really tricky territory.
Challenging.
Yeah, very challenging.
Yeah, it can go horribly wrong.
Yeah, absolutely. It's so multifaceted.
Yeah.
And to not have a guide, I think would be a little bit questionable unless there's a reason for it.
Yeah.
And that's not me saying you need a guide, by the way. I'm just, making statements.
Yeah.
For RP4, RP5, so overdenture work, I would also state that there's a really strong place for it.
Yeah.
I don't think a lot of people are aware, but for overdenture work, conventional traditional overdenture work, if you think about it, you don't have the flexibility of tilting implants. They should be parallel to each other. So you can put your locators or whatever parallel to each other. So retention and resistance is as good as possible.
I think one of the bits that's missed, and I certainly have done it over the years many times, is the restorative space required.
Absolutely.
For overdentures.
Absolutely, yeah.
It's a major thing that people don't think about.
I see that all the time because people, a lot of clinicians and colleagues will think, take the teeth out, just put the implants in, overdenture, as opposed to not only do the implants have to be parallel, they need the same space requirements generally.
Sometimes even more.
Sometimes even more. So generally, if you're doing a bar, you're looking at 15 mils.
Yeah.
If you're not doing a bar, you could probably get away, and it's just locators, you could probably get away with 12 mils.
12 to 13.
But, if it's an upper, it classically needs to be splintered for maxillary overdentures. Lowers, you could get away with unsplintered locators. But for uppers, I would always recommend splintered. But even for lowers unsplintered, you're looking at minimum of 12 mils, and it's surprising how many people do not take that space requirement.
Well, I know from the work that we've been doing over the last number of years with chrome guided smile, we've received more and more of these types of cases in, and we know there's a product that's being developed for overdenture work because it's the fact that people do not plan restorative space that they end up with so many restorative issues. And it's the restorative issues that kill you. That's the bit that causes the stress.
I think that's one advantage of guided, because it really highlights that clinician's lack of knowledge. Because I know how to plan the restorative space, because I know the restorative space is based on this. Yes. And the amount of clinicians and course teachers, because that needs to be highlighted, who teach full arch courses, and you ask them, how have you worked out the alveoplasty? And they don't know. They'll say, oh, it's just roughly about this. No, it's not roughly. It has to be a specific number based on this.
Yes.
And there's a lot of people out there that don't understand how to work that number out. And it's highlighted when you plan a full arch case.
Yeah. Okay. So thank you for that. That the next bit that I want to cover with you, if that's okay, is to look at the more atrophic side of things, which is obviously an area that you're extremely experienced in. And it's challenging surgery, it's challenging planning, but the execution of it is also, it requires a huge amount of skill, feel, touch, all of those things. And to do that guided it's a huge leap. Okay. I know we were laughing earlier on where people have contacted you because you've been involved in doing some of this with me and not happy with you. Not happy with you. So, my attitude to that is that's good. It creates a conversation. Okay. So we have now done, so you've been at the centre a few times. Okay. And we're now on the bit that we're doing, the second iteration of a zygomatic guide, so zygo chrome guided smile guide. And we've done 2 cases over the last 2 days. Both single zygos, one on each side with some anterior implants. Quite difficult cases, atrophic zygomatic cases.
That last one especially, so
And so how do you think that it has gone, okay? Given an honest appraisal, because that's really important, that, how good do you think it's been?
It's interesting, isn't it? Because the last 2 days we've done these 2 cases, which is the second version of the guide. The first version, for those first few cases, I came home thinking it wasn't, there was a benefit in terms of you can visualize the trajectory of the guide actually being there. I'm not sure if the benefit versus the cons outweighed
Yeah.
because of the time taken to put the guide on, and you know, how useful would it have been. Yes, it helped me outline potentially and help visualize my trajectory, but that's about it.
Yes. Yeah.
So I was questioning that. And again, you know, people ask me, why was I doing that for? I had quite a few messages from various people from various countries.
Yes. Yeah.
Asking, you know, why would you be so silly? Especially because I had, for some of these people, I had input in their training in zygos and pterygoids and stuff. So, and during the courses, I would always be quite vocal. Guided will never work for this.
Yes.
You know, it's foolhardy.
Yeah.
And that's because my second MSc on zygos and pterygoids were, you know, part of that. There was an aspect of guided pterygoids and zygos from Luke Vreeling. I don't know if you've heard the name.
I've heard the name. Yeah.
A lovely guy.
Yeah.
Very experienced zygo and pterygoid max-vac surgeon based in Belgium. Mm-hmm. And his paper really damned guided, and he was very open-hearted in trialing out guided surgery for this type of work. But the divergence and convergence measurements from the planned to the actual and the comparison was so significant. Miles out. So significant, especially with the pterygoids, because you can't open and raise a full-on flat.
Challenging.
Very challenging. Mm-hmm. And that massively influenced me. But that was, you know, well over a decade ago now. Yeah. Things have moved on. And I didn't want to be in a position where, you know, I'm in this place where I teach people and I'm making statements based on no evidence whatsoever. And yes, I did guided surgery or do guided surgery, never done guided surgery with zygos. So how can I have an opinion?
Yeah.
You know, it's all very well with people saying, you know, why are you saying this and that? You know, at least I can say I'm doing it. I can base my opinion on my experience. You're basing your opinion on what?
Yeah.
Everyone can have an opinion, but you either have an experienced opinion or a completely non-experienced opinion based on nothing except your own thoughts.
Yeah. Or what else you've heard.
What else have you heard? Yeah. And I didn't want to be in that camp of I'm basing my opinions on something that run through my head. Yeah. So hence the reason why I thought it would be a good idea for me to try it.
Yeah.
So the first few cases, you know, I was really questioning where this is going to go. And then we had those meetings, virtual meetings for these last two cases. And actually, you know, God as my witness, I'm actually pleasantly surprised. I wasn't pleasantly surprised on the first case and the first zygo. The first case and the first zygo that's been put in, I questioned myself. Why am I doing this for? I would have finished, finished this case ages ago. But then, you know, you learn from your mistakes. And that's what experience is, isn't it? You're learning from your mistakes, not when things go well, but when things go not so well, so you can learn from it. So then the second zygo on the first patient, that went really well. I was really happy with that. You took a photo of it. And that was spot on. Because I could learn from that.
And I think, not to interrupt you, I think that's a really important point, which is that there is a technique to using guided surgery.
Absolutely. Well, especially with this type of guide, it's massively technique sensitive. Especially because this is the second trial of the second type of guide, and we already know I was doing it blind. It's a longer implant, so you know, any small deviation of that drill will have significant changes in the angle and putting you off. So not only was I doing it blind, I was doing it purely by feel. And that's difficult. It's not something I would recommend to anyone to do zygo surgery guided unless you have developed a certain level of anatomy, certain level of feel with the drill, and a certain level of knowing where you are when you're drilling. And that only comes with time and numbers and so on. So for these guides, that's what's required. However, going forward with this new guide, after we've done these cases and the small changes we're going to do, I think we're getting closer and closer where, you know, how easier is it going to be? And I think it's going to be significantly easier. You know,
you one of the comments I thought was quite interesting during it was that you felt the prep was really quite minimal.
I was really, you know, I generally come from the background of doing zygos where I want to see exactly where I'm going. I know some countries, for example, won't raise the flap fully, so they won't see the exit point. Because I work in the UK, I want to see exactly where I'm going. If that was me, I want to know exactly where I'm drilling. So I want to raise a flap so I can see the exit point, the entrance to the zygo, and the coronal prep, and the prep to the lateral wall. So sometimes I raise a big flap, which I still will always do, but my anatomy, I will raise the sinus window so I can see the drill, I can see the undersurface of the zygo, I know exactly where I'm penetrating into the zygo and where I'm exiting. So to me, that is as safe as I'm going to go for my patient. But with the guide, however, because I could see the trajectory and I was forced into that trajectory, there was an element of I had to trust it, but I'm never going to trust anything fully. So I was going, quite slowly.
Very steady.
Yeah, very steady, conservatively, and going by feel. But actually, when I took the guide off, because I was happy with the prep, I could reflect and see how minimal that prep was, and also that I was in the correct position. Especially this last case.
So it was interesting because from an observational point of view, watching you doing it, I'm going to say that you got better in terms of physically being able to utilize the guide. And that's something that we see, that I go around teaching people how to do full arch guided surgery. And that's what you see in the progression. You get better and
the feel of the guide.
Different.
The feel There's an element of trust because while the guide was in place, I was forcing myself to go where I wanted, and the guide was pushing me back where the guide wanted.
The plan was.
Plan was. And actually the post-op APT, I'm a person of symmetry. I like everything to be symmetrical and mirrored. And this last case, we knew wasn't going to be like that because we had planned it
more vertical
on one side because the zygo was so much thinner. It was such a narrow zygo. So the penetration was more vertical, so I'm engaging more bone. And actually, if you look at the post-op APT, although it looks completely skew-with, it's exactly where we had planned it.
And I thought also, we're not there yet on the restorative pickup bit. We've got a wee bit of work to do there. But I think we both agreed that we learned from the first case. And that the second case, restoratively, is going to be fantastic. We're in a really good place. So, and we were able to, I suppose, load both cases. Okay, patients went away happy. So that's brilliant.
I think the restorative bit, that was probably my fault because I didn't highlight the differences between the different types of restorative platforms and how that changes your surgery and pickup.
Listen, it's been a huge learning curve. Just think what the little tweaks, turns, the marginal gains we'll make now on V version 3 which I think will make it even better. And I think there's obviously still a little bit of work to do there, but certainly from my perspective, it was great to see that we completed the cases, we completed them safely.
Using the guide.
With using the guide all the way.
All the way,
which was fantastic.
Whether that's in research terms or in clinical terms, that term of reliability where something can be done and reproduced by the vast majority of people, that's the question mark. Because although this was all done successfully, we used the guide all the way throughout. Everything went really well. We loaded. That was specifically with me using it.
Totally.
Whether it can be reproducible.
Well, let's talk about that. So we're both keen, obviously, to continue to develop this. Okay, and I think we've both agreed on that. We've also had a conversation about where education fits and training, because that's something that we're both very passionate about. Okay, and so we've also talked about potential pathways for people to be involved in this at a time that we feel it's a predictable way of working. So how, where do you see that training and education? Because I think it's very important that we state at this point that this is not something that Chrome Guide Smile is going to start firing out all over. Okay, because there's a responsibility to the patient, to the patient that we get this as right as possible. But there has to be training involved in this. How do you see that potentially forming over the next 12 months?
I mean, that's a massive question. I think the only thing I would say is, utilizing the new mentoring guidelines, which
Yes.
ITI, ADI, and CG Dent, FGDP, whatever we want to call them now, has really promoted and highlighted. I don't think people are using that actually yet, because I see implant companies and other organizations and private mentors going around mentoring when they're not really qualified to be mentoring themselves. But first and foremost, if a training program or a mentoring program is going to come about, to use those guidelines, they were, formed for a reason, number one. And then number two, like any kind of mentoring or upskilling, it's a case of do this many cases, potentially free-handed, definitely with a mentor.
Yeah.
And then your mentor helps you go through the path of a guided version of that.
Yeah.
I mean, that first case with the first implant, not the second one, I was in the right place.
Yeah.
And I knew that because of experience.
Yeah. But what probably for me was at the drilling, you used two totally different drilling sequences.
Yes.
That was the learning.
That was the learning curve. Yeah.
That was the learning.
Yeah, to use a drill that flexes was always going to be wrong.
Yeah.
To use it in a guide.
Yeah.
Was always going to be wrong. It's okay in a free-handed approach, but not for a guided approach, which is why all the other implants did.
Oh, yeah.
Once we learned from that, everything else was bang on.
Yeah.
But yeah, I mean, just to know those differences, to know what to be used in freehand, what to be used in guided.
Yeah.
That's going to come with time, and I don't think you should be doing the guided until you're competent.
You got to be a competent surgeon, a very
absolutely.
competent surgeon, I would argue.
Yeah. For this type of stuff, because things can go massively wrong.
Yeah.
It's not that long ago I saw a zygo case and someone hit the eye.
Yeah.
And that's not the case I was talking to you about with the consultant doing it. This is a different case.
Okay.
So that still goes on, which is quite scary.
Yeah, it is.
Yeah.
Okay. Well, we'll wrap it up. Okay, if that's okay. The last thing I want to ask you about is that, so you've been to the centre a few times.
Yep. This seems controversial. He's got a smile on his face. There we go.
Yeah, you know what I'm going to ask you.
I know.
So you'd never been to Fermanagh before until you came here.
No.
Okay, this is your third visit, I think.
Yeah, but I've been to the Mackin Hills.
Oh, of course.
Yeah.
Okay, so that's good.
But that again was getting off the plane, taxi, do the zygo, getting back on. And in the car, you just look at how amazing.
Yeah.
Because I don't know if this is true. When I come here, the sun hits the green differently.
Yeah. The sun's out now. The sun is out again.
Yeah, I mean, look how vibrant it looks.
Yeah.
It's a very different green from England, anyway.
So, what do you think of the centre? We've only been in 2 years.
Yeah.
Okay. And we're trying to create this from scratch.
Yeah.
And do the type of stuff that we're doing. What's been your impression of the centre and coming here to work as a clinician?
You already know what I think, don't you?
Yeah, but I want you to tell them.
Oh, right, okay, yeah. I mean, it was only just this morning again. I was walking around recording the centre, so I can go home and show my wife, look at how good this centre is, because I go to a lot of really high-end clinics, a lot, abroad and in the UK, and a lot of these clinics blow my mind. There are some. Yeah. I'm truly honoured, not just in terms of the cases I do, but where I work. Yeah. Some of the places I work have been exceptional, and some have not been so exceptional. Yes. I'm lucky and I'm happy if I have lights and I've got my motor and my equipment. That's all I want. But when you walk into a centre where it's, it blows your mind, or it takes you, it gives you a moment of a step back to take it in. That's really quite nice, and this place is exactly that. It's the reason why I'm constantly having my phone out recording it all, because it's a world-class centre. It's really nice, actually, to be honest with you. Forgetting the camera. I don't know if you're still recording this or not, but it's a lovely place. It really is. Each time I walk around, I don't know if you know this, but I finished a surgery and I'll have a walk around.
Oh, I wonder where you disappear.
Yeah, that's what I'm doing. I'm just this is even the small things, like hitting the door for the door to open automatically, as opposed to touching the door handle. Yeah. That in itself is quite a nice touch. Yeah. Or the the centre where you've got the TV set up, so video can be streamed where we're doing. So it's lovely. It's really nice.
So it's a pleasure to have you over.
Very kind.
It's a pleasure to have you over.
It's really nice coming over. Hence why I've brought the other lot with me.
Yeah, you brought your family this time.
Yeah.
Okay. Listen, Pynda, thank you very much. All right.
Good.
It's always a pleasure to chat to you.
Yeah.
Okay. Listen, that's the end of the first little interview. I hope that you get something from it. And it's been, as I say, once again, a pleasure to have Pynadath with Pynadath. No wonder people call you George. Yeah, it's a bit easier. But it's been an absolute pleasure to have you.
I love coming here, James.
Super.